This is Radio Health Journal. I'm Reed Pence. This week, shortages of life-saving medications.
You really put between a rock and a hard place, and you are now suddenly having to sit with a kid and the parents and telling them, we may not be able to cure your otherwise curable cancer.
Drug shortages when Radio Health Journal returns.
If you're one of the nearly 30 million Americans with diabetes that regularly test their blood sugar, you rely on your meter to help you and your healthcare professional detect high and low blood sugar and make therapy and lifestyle adjustments. Now the new One-Touch Vario Flex meter with ColorSure technology takes the guesswork out of interpreting results. Endocrinologist Dr. Jeremy Pettis explains.
Many people with diabetes have difficulty making sense of their blood sugar results. The One-Touch Vario Flex meter has a simple color range indicator that uses blue, green, and red to instantly tell you when your readings are low, in range, or high. And for patients who want additional insights and information, the meter connects wirelessly with the One-Touch Reveal mobile app on iOS and Android devices.
Simple, accurate, and easy to use, the One-Touch VarioFlex meter is available now with an estimated price of under $20. One-Touch is the brand most recommended by endocrinologists and primary care physicians. To learn more, visit onetouch.com.
Doctors have an incredible array of medications to treat disease. Some drugs attack the disease itself, like chemotherapy drugs. Others, like anesthesia, assist in surgery or other procedures. And some drugs, such as pain medications, treat the symptoms of disease or trauma. Doctors can use the very best medications for a given patient, unless they can't get the drug at all. Drug shortages are surprisingly common.
These drug shortages have been going on in their current form for well over 10 years, and they reached a peak just a couple of years ago with 320 drugs in short supply, and they span the classes of drugs. So it's not just chemotherapy, which is what I'm interested in per se. It's really drugs of all class. So it's critical care drugs, antibiotics, ICU drugs, essential electrolytes and minerals. There's actually a shortage, believe it or not, of normal saline, that's salt water.
That's Dr. Yoran Unguru, a pediatric hematologist-oncologist at Children's Hospital at Sinai in Baltimore and a faculty member at the Berman Institute of Bioethics at Johns Hopkins University.
Presently, if you look at the data, there's somewhere around 150, 155 drugs in short supply. The majority of these drugs belong to a class of what's called generic sterile injectables. And what that is really in English is that these are drugs that are often given in the form of an IV solution. These are drugs that have been around for decades. The important thing to keep in mind is that they are the backbone of proven and life-saving regimens for kids with cancer. And the added insult here is that we have very few, if any, alternatives. So it's not that you have an ear infection and you have your choice of a variety of antibiotics to treat if one of them is short. You're talking about very specific drugs that are required for a given childhood cancer, and without them, there is no alternative.
We do have quite a few drugs in short supply now, and there are quite a few of them that are critically important to care. I could give you some examples of those, but I think one of the most striking is BCG vaccine, which is used for bladder cancer, and it has very few alternatives in the drug armamentarium. The usual alternative is surgery, and so this is really serious for patients with bladder cancer.
Pharmacist Bana Benjamin is Director of Medication Use Quality Improvement for the American Society of Health System Pharmacists. She says there are a lot of complicated reasons some of these drugs are in short supply, and we'll talk about some of those reasons in a few minutes. But whatever the reason, the effect is the same. Pharmacists and doctors now find it part of their unfortunate routine to work around shortages and try to be prepared for them.
At one time, shortages were kind of an incidental thing that was just annoying. Now, drug shortages are an everyday issue in patient care. So most hospitals, in fact, probably all, have proactively developed protocols that help their care providers with choosing alternative drugs or what we call conservation protocols when the drug becomes short. So you would review your drug inventory and your drug utilization statistics. You would pick the drugs that you know are critical to care, and for those you would develop backup plans.
Benjamin says the goal is to make the shortage invisible to the patient. Simple steps may involve conserving drugs, using smaller IV bags of saline, for example, rather than a large one, and expecting to throw out what's left. After those steps, things get a little tougher.
What we first look for are therapeutic equivalents or therapeutic alternatives that may not be equivalent but are similar in their ability to produce a specific outcome for a patient. So, for instance, for antibiotics, there are many drugs in the class of antibiotics. If you don't have one, you have many options to pick from that might do just as well, or might even do better, but are maybe more expensive, or maybe a little bit more difficult to prepare and administer. But you have a lot of alternatives.
We haven't been pushed to a point where we have felt that it's been unsafe to practice because of those shortages.
That's Dr. Brian Fitzsimmons, a cardiac anesthesiologist at the Cleveland Clinic Foundation.
We've always been able to find substitutes. It's usually a question of then tailoring an anesthetic prescription around a different side effect or just biting the bullet and absorbing the higher cost for those drugs.
However, where no substitutes exist, Benjamin says the scrambling begins.
For drugs like sodium chloride injection, there really isn't a lot of alternatives for patients who are severely dehydrated. So your planning may involve something like, can we compound this drug from, say, FDA-approved injectable components? Or can we find a way to perhaps share the supply among all the organizations in a particular area so that all patients have the advantage of access to all that we have here?
However, if a drug in short supply has no substitute, no way to compound it, and nowhere else to get it, that leaves doctors having to stretch what little they've got until it runs out. They have to make life-and-death decisions to ration.
What do? Do you skip a dose? Do you give a lower dose? Let's say you do decide that you want to allocate drugs among equally deserving kids. How do you go about doing that? Imagine that you're the kid or that kid's parents, and suddenly your doctor says, you know what, we have enough drug for just a couple of you or one of you, and the rest of you don't get it. You really put between a rock and a hard place, and you are now suddenly having to sit with a kid and the parents and telling them, we may not be able to cure your otherwise curable cancer just because you don't have a drug. That doesn't seem right.
But how far do you go to grasp at straws? Ungaru says sometimes doctors can find a drug that might be an alternative, but with little data that it's more effective, it can be a roll of the dice.
In 2009, there was a shortage of an old tried-and-true chemotherapeutic called mechlorethamine. This is a particular chemotherapy drug that's been around for decades, and it's used to treat adolescents and young adults with the form of Hodgkin lymphoma, a very common type of cancer. And at the time of this shortage of this particular drug, evidence suggested that there was another drug that was as effective. So a number of the kids got that alternative drug in their cocktail, and they had a much higher rate of their disease coming back and relapsing than the kids who got the standard of care, the mechlorethamine. And while there were no deaths associated with that, these kids got exposed to significantly more rounds of chemotherapy, even bone marrow transplantation, and these are very toxic therapies, so it's not even clear what's going to happen to these kids down the road.
A panel of children's oncologists has drawn up guidelines on the allocation of scarce drugs because doctors say they need more help making those decisions fairly and ethically. Ungaru was on the panel, and he says one study found that 70% of adult cancer doctors don't get guidance from their hospitals.
Oftentimes these decisions are left until the rubber hits the road, there's a shortage, and it's the bedside physician who is forced with having to make this decision. And in the heat of the moment, there's no question, of course, that bedside physician is going to advocate for her patient. But that's not the way you want to do it. Bedside decision-making is inefficient, it's not very comfortable, it's not very ethical. So we came up with a task force, and we developed a whole set of recommendations for how one goes about doing this based on a couple of premises. One is, as much as possible, we should mitigate these shortages based on maximizing efficiency and minimizing waste. So if you think about the water shortage in California, that's a perfect example. You don't water your lawn as much, or you convert from grass to stone, or some other means. That's your first step. When you're forced, however, to allocate, when you have no choice, then there's a number of factors that we recommend.
Among the factors to consider, curability and the importance of a particular drug to a patient's condition. The guidelines don't say to distinguish between children of different ages, but what about children versus adults? Some hospitals give preference to those with more life yet to live. Benjamin says it's a lot like the ethics of organ transplant application, but Unguru says it's a national disgrace.
We're talking about curable diseases. We're talking about the most vulnerable of vulnerable, kids with cancer. The status quo is actually forcing us essentially to serve as a death panel. This notion of having to pick which kid is more worthy of a drug is really untenable. Although an ethical framework for allocating is necessary and appropriate, that's not the solution.
The solution, Unguru says, is solving the reasons shortages occur in the first place. Some of them are economic and result from government restrictions.
More than 10 years ago, in an effort to try to curb these high costs, the government stepped in and passed something called the Medicare Prescription Drug Improvement and Modernization Act. And what that does is it reimburses Medicare for these sterile injectables based on a very small margin. So some of the companies will say, you know what, it takes a lot of effort and a lot of money to produce these drugs, and if we're not getting a lot of return on our investment, we're not going to continue to make them. And there's very good data that shows that since that act was passed, there's been an increase in these shortages.
Production problems are another common reason for shortages.
Injectables, even the very simple ones, such as sodium chloride injection, which is just salt water, have a complex manufacturing process, which has many complicated steps. So there's a lot of opportunities for something to go wrong.
And when something does go wrong, it's not as if another company can ramp up production to make up the difference.
Very few companies actually make these sterile generic injectables. As recently as just a few years ago, 3 companies in particular made 70% of all the sterile generic injectables. Now imagine that they have a problem with one of their production lines. Suddenly, you've got a shortage of a drug, and it takes a long, long time. You can't just call a friend and say, hey, can you make this for me? It doesn't work like that. These are very complicated lines. And oftentimes, because the production lines are very complicated, usually more than one drug is made on the same line. So if that line goes down for whatever reason, you can imagine that now you're faced not just with one shortage, but with some others as well.
Unguru says government action to revise Medicare payment rules would be a good start to solve some of the drug shortage. Changing rules prohibiting transfer of drugs between states could also help ease regional shortages. But he says a more basic change in how drugs are produced and paid for will likely be needed. In the meantime, hospitals will have to continue to stockpile critical care drugs and hope that the supply stretches far enough. You can find out more about all of our guests on our website, radiohealthjournal.net. You'll also find archives of our programs there, and you'll find them on iTunes and Stitcher. I'm Reed Pence. Radio Health Journal returns with medical notes in just a moment.
A new survey shows a staggering number of family and friends of people with Alzheimer's disease are jeopardizing their own family's health and financial stability. According to the Alzheimer's Association 2016 Alzheimer's Disease Facts and Figures report, nearly half of care contributors have to cut back on their own expenses and basic needs, such as food and medical care. Beth Kallmeyer is Vice President of Constituent Services for the Alzheimer's Association.
Very few people are prepared for the high cost of dementia-related care. More than 1/3 of care contributors experience significant lost income due to caregiving demands. For example, they must cut back on their own expenses, including basic necessities like food, transportation, and medical care.
Kallmeyer says families need to proactively plan for the financial impact of Alzheimer's and dementia. Planning tips and more about the 2016 Facts and Figures report are available at alz.org.
Medical notes this week. Doctors have long sought reasons why people who don't smoke develop lung cancer. Now they may have found one: too many carbs. A study in the journal Cancer Epidemiology, Biomarkers and Prevention finds that people who eat lots of carbohydrates with a high glycemic index have a 49% higher risk of developing lung cancer. So avoiding white bread and white rice may be good for your lungs as well as your waistline. If you give kids too much yummy food, they'll overeat. Now, that may seem intuitive, but a study in the journal Physiology and Behavior confirms that children can't regulate how much food they eat. Researchers found that if kids are served a tasty meal up to about 80% larger than normal, they'll eat it. However, there's some good news in the study. It works the other way too. Kids don't feel unsatisfied when they get smaller portion sizes. And finally, as many as 16 million Americans may suffer episodes of explosive, violent rage, a disorder called intermittent explosive disorder. Now, a study in the Journal of Clinical Psychiatry suggests that their cat's litter box could be one reason why. People diagnosed with IED have more than double the likelihood of being infected with a parasite often found in cat feces and undercooked meat. And that's Medical Notes this week. More in a moment.
Thank you for listening to Radio Health Journal, a production of MediaTrax Communications. If you enjoyed this week's show, please leave a review on iTunes or share it with a friend. You can find more Radio Health Journal stories about health, science, and technology on iTunes, Stitcher, and at radiohealthjournal.net.